Welcome to the Deep Dive. Today we're embarking on a truly vital and, let's be honest, often deeply misunderstood journey. We're exploring the landscape of psychiatric medications.
That's right.
We've pored over this fascinating collection of notes and resources we received. It's almost like a backstage pass to the mind's pharmacy, really.
Right.
Covers everything from, the heavy hitters for psychosis to the more delicate balancers for mood and anxiety.
It's quite a range of tools we're looking at.
Absolutely. So our mission in this deep dive isn't just to list these medications. We want to truly understand them. How do they actually work their magic or sometimes their mischief inside our bodies? What are they aiming to achieve? And, maybe most crucially, what are the essential safety considerations and side effects you need to be aware of?
That safety piece is paramount.
We want to equip you with those vital aha moments, turning dense info into clear, actionable knowledge.
And what's truly fascinating, I think, is how these medications try to precisely target specific neurotransmitters and pathways deep within the brain, or what we sometimes call the central nervous system, the CNS.
Right, the CNS.
We'll be looking at the subtle nuances that differentiate them and why, frankly, grasping these details is so important for safe and effective treatment.
Yeah.
It kind of raises an important question for us, doesn't it? How do we pull out those core principles without getting totally lost in an overwhelming sea of medical jargon?
Exactly. It can feel like learning another language.
It really can, but that's what we're here to do, to sort of guide you through this complex yet incredibly important territory.
Okay, let's dive in then. Let's unpack our first major category, antipsychotic medications. These are, powerful drugs primarily designed to block dopamine receptors, which ultimately decreases dopamine concentrations in that central nervous system we just mentioned.
That's the main idea.
They're really indispensable tools used for conditions like reducing the severe symptoms of schizophrenia and, importantly, significantly lowering the risk of relapse.
Historically, our journey began with what we call first generation, or typical antipsychotics. Names like chlorpromazine, maybe haloperidol, you might even hear that one, Holdol, used in, acute situations.
Right, for immediate control.
Exactly. To quickly help manage severe psychosis, these early drugs were kind of a blunt instrument, you could say. They primarily treated what we call positive symptoms of schizophrenia.
Positive symptoms.
Right.
That's things like hallucinations, delusions.
Precisely. Hallucinations, delusions, and that profoundly disorganized thinking. Their core mechanism was a very strong, very broad blockade of dopamine D2 receptors.
Okay, when I was reviewing the notes for these first-gen drugs, one detail really jumped out. It wasn't just dopamine they were hitting, was it? Can you break down those other effects, why they cause such distinct side effects?
Absolutely, that's a critical point. The powerful dopamine blockade worked, yes, but these typical antipsychotics also significantly blocked other receptors, acetylcholine, norepinephrine, and histamine all throughout the body.
Wow, okay. So widespread effects.
Very widespread. And this leads to some really memorable and often quite uncomfortable anticholinergic side effects. You might hear them summarized with that classic phrase.
Ah, I think I know this one. Can't see, can't pee.
That's the one. Can't see, can't pee, can't spit, you get the idea. Constipation.
Right.
And that translates directly to blurred vision, difficulty with urination, a very dry mouth, and yes, constipation. These weren't just minor annoyances. They were real quality of life issues for people. And beyond those, a major, really challenging concern with these first-generation drugs was extrapyramidal symptoms, or EPS.
EPS, okay.
These are a whole spectrum of involuntary movement disorders that cropped up because of that dopamine blockade in a specific brain area, the nigrostriatal pathway. It's basically the brain's critical movement control center.
So you're messing with movement control.
Directly. Imagine, losing fine control over your own movements.
That sounds terrifying.
It could be. One type is pseudo-Parkinsonism. You'd see muscle rigidity, a shuffling kind of gait, slowness of movement, tremors, even when someone's resting, very much like Parkinson's disease.
Okay.
Then there's acute dystonia. This was sudden, often painful, sustained involuntary muscle contractions. Could be a twisted neck, eyes rolling upwards involuntarily, jaw spasms.
Oof.
Yeah, and it was considered an emergency because, potential for airway issues.
Right.
And then the profoundly distressing akathisia, This is an intense inner restlessness, just an inability to sit still. People would pace, rock back and forth, constantly shift their weight.
That sounds awful, almost like torture.
It was often mistaken for worsening psychosis or anxiety, but it's a distinct side effect needing its own treatment approach, like
Right.
beta blockers. And finally, a really serious long-term worry: tardive dyskinesia. This showed up months or even years into treatment. It involved involuntary, repetitive movements, grimacing, lip smacking, tongue protrusion.
And that one was often irreversible, wasn't it?
Sadly, yes, often irreversible. The existence of all these side effects, especially tardive dyskinesia, really highlighted the urgent need for something better.
So with these first-gen drugs, it sounds like a tough balancing act. You're addressing one set of severe symptoms, but potentially creating these really profound physical challenges. How big of a trade-off was that in practice? What drove the push forward?
Oh, it was an enormous trade-off. It led to significant distress for patients, naturally, and often poor adherence to treatment. Who wants to take a medication that makes them feel like that?
Makes sense.
So this drove intense research, thankfully, and we saw the arrival of the second generation, or atypical antipsychotics, drugs like risperidone, olanzapine, clozapine.
Okay, the atypicals.
And beyond those, even third-generation drugs like aripiprazole, which you might know by the brand name Abilify.
Right, Abilify.
These newer drugs really did change the game in many respects.
How so? What was the big improvement?
Well, they're a big step forward because they treat both those positive symptoms. We talked about the hallucinations, delusions, and the negative symptoms.
Ah, right. The negative ones are like apathy, social withdrawal.
Exactly. Apathy, withdrawal, that sort of blunted emotional range. They can even help with mood symptoms sometimes associated with psychosis.
Okay, so broader coverage. And how did they work differently?
The key difference in their mechanism is they generally have less potent, maybe more nuanced dopamine blocking activity. And critically, they are also serotonin receptor antagonists.
Serotonin, too. Interesting.
Yes, and that serotonin blockade is crucial. It's thought to be what helps significantly decrease those really troubling extrapyramidal side effects, the EPS.
Fewer movement problems, then. That's huge.
It was a major advantage.
And what about those third-generation ones, like aripiprazole? What makes them stand out even more?
Yeah, the third-gen drugs take that nuance even further. They're not just blocking receptors. Think of them more like a subtle dimmer switch. They act as partial agonists at some dopamine and serotonin receptors.
Partial agonists, so they activate them slightly.
Kind of. They provide some stimulation, but not full stimulation, while also blocking overstimulation. And they act as antagonists at other receptors. This more balanced approach allows them to fine-tune the brain's signals,
Okay.
which often leads to even fewer motor side effects compared to the second-generation drugs, which were already an improvement over the first.
These certainly sound like a significant step forward, treating more symptoms, fewer movement issues.
Right.
But I imagine it wasn't a magic bullet, right?
Yeah.
What new challenges or serious risks popped up with these second and third gen drugs?
That's a really powerful point. It definitely underscores that newer doesn't always mean simpler or risk-free, not at all. While generally having a lower profile for those motor issues, these atypical antipsychotics still come with their own set of serious risks. They require critical safety monitoring. Clozapine, brand name Clozaril, is a prime example.
Clozapine, okay. What's the issue there?
It's highly effective, often used when other drugs haven't worked, for treatment-resistant schizophrenia. But it requires a very strict monitoring program. Why? Because of the risk of agranulocytosis.
Granulocytosis. That sounds serious.
It is. It's a life-threatening condition. Basically, a severe drop in neutrophils. Those are white blood cells crucial for fighting infection. The immune system essentially fails.
Wow. So regular blood tests are needed.
Absolutely essential. Strict protocols. Patients might get flu-like symptoms, a sore throat, fever, signs their immune system is compromised. Clozapine also carries an increased risk of seizures, especially if combined with ECT, electroconvulsive therapy.
Okay, so clozapine is effective but requires intense caution. What else with the atypicals?
Another significant concern with many of these atypicals is something called metabolic syndrome.
Metabolic syndrome. Can you explain what that involves and why it's such a big deal?
Yeah, metabolic syndrome isn't just one single thing. It's more like a dangerous cluster of conditions happening together.
Okay.
We're talking significant weight gain, dyslipidemia, that's unhealthy levels of fats like cholesterol and triglycerides in your blood-altered glucose metabolism, potentially leading to diabetes and hypertension or high blood pressure.
So a whole collection of risk factors.
Exactly. And all of these together dramatically increase the long-term risks for serious health problems like heart disease and type 2 diabetes. This isn't just a nuisance side effect. It's a profound physiological shift that needs careful monitoring weight, blood pressure, blood sugar, lipids.
Makes sense. Constant vigilance needed there.
Absolutely.
And finally, there's a medical emergency we should touch on. It can happen with any antipsychotic, though maybe more common with the older ones. Neuroleptic malignant syndrome, or NMS.
Yes, NMS. Thankfully rare, but potentially fatal maybe around 10% of cases, tragically.
10%. Wow.
The signs are stark and come on quickly. You see a decreased level of consciousness, profound muscle rigidity, like lead pipe rigidity, a very high fever, what we call hyperpyrexia,
Hyperparesia, okay.
a racing heart, tachycardia, and autonomic dysfunction. That affects things like blood pressure, sweating, basic bodily regulation. It goes haywire.
So what do you do?
If NMS is suspected, it's a code red, a medical emergency. Stop the antipsychotic immediately. Get intensive supportive care, cooling, hydration, managing cardiovascular instability. It's critical.
Okay. That's a lot to take in just on antipsychotics.
Yeah.
Powerful tools, but clearly needing respect and careful management.
Absolutely.
Having wrestled with those, let's maybe shift gears now to a different but equally vital family of medications. Those designed more to gently adjust mood and manage conditions like depression and anxiety.
Right. Moving into antidepressants. Here, SSRIs, selective serotonin reuptake inhibitors like fluoxetine, brand name Prozac, are often the current drugs of choice for depression.
SSRIs, yeah.
Yeah.
Heard of those. How do they work again?
Their mechanism is basically to block the reuptake of serotonin. Think of it like partially plugging the drain for serotonin in the synapse. It leaves more serotonin available in that space between nerve cells to send messages.
More serotonin floating around.
Essentially. And a really crucial piece of patient counseling here is that they take time. They don't work overnight, often several weeks for the full therapeutic effect to kick in.
It's important for people to know, right? Don't give up too soon.
Exactly. Then we have SNRIs, serotonin norepinephrine reuptake inhibitors. Venlafaxine, or Effexor, is an example.
SNRIs. So they hit norepinephrine too.
They do. They act on both serotonin and norepinephrine pathways. Because of that, they're also used for anxiety disorders and even some types of chronic pain.
Interesting. Wider application.
Yeah.
And then there are the older classes, right? The TCAs, tricyclic antidepressants like amitriptyline, and the MAOIs, monoamine oxidase inhibitors like phenelzine or Nordil.
Yes, the older guard.
Right.
Powerful, effective in their time, and still used sometimes, but they come with significant considerations.
And those considerations lead us straight into some critical side effects, don't they?
They certainly do. With SSRIs, while generally safer, you can have too much serotonin activity, leading to serotonin syndrome.
Serotonin syndrome, what does that look like?
It can present with symptoms like high blood pressure, motor restlessness or agitation, overactive reflexes, sweating, tremor. It can range from mild to severe.
Okay. And the TCAs?
With TCAs, the big danger is overdose. They can be fatal in overdose, primarily due to cardiotoxicity affecting the heart rhythm and neurotoxicity impacting the brain. You can see rapid onset of dangerous heart rhythm, seizures.
Scary stuff. Needs careful prescribing.
Very careful. And with MAOIs, this is where those serious drug-food interactions become critical.
Ah, the tyramine thing.
Exactly. You must avoid tyramine-rich foods, things like aged cheeses, smoked or cured meats, fermented foods like sauerkraut, some beers and wines.
Why? What happened?
If you eat those foods while on an MAOI, you risk a life-threatening hypertensive crisis. A sudden, severe spike in blood pressure, intense headache, chest pain, another medical emergency.
Wow. So diet is absolutely critical with MAOIs.
Non-negotiable. Strict dietary adherence is vital.
Okay, moving on. For conditions like bipolar disorder, where people experience those dramatic shifts in mood from mania to depression, mood stabilizers are absolutely key.
Absolutely central to treatment. And here, lithium is often considered a first-line treatment. It's thought to work by stabilizing electrical activity in brain cells.
Lithium. I know this one comes with a catch.
It does. Here's the critical part. It has an extremely narrow therapeutic range. Think of it like walking a very, very fine tightrope.
Narrow range, meaning?
Meaning the difference between an effective dose and a toxic dose is tiny. We measure it in the blood, and the target range is really small, like between zero point 0.6 and 1.0 or 1.2 milliequivalents per liter. Levels just slightly above that, say 1.5, can cause toxicity, drowsiness, coarse tremor, confusion.
And higher.
Above 2.0 or 2.5, you can get into severe toxicity, ataxia, seizures, stupor, even coma, and potentially death. It's serious business.
So for you or anyone you know listening who's on lithium, consistent sodium and fluid intake is absolutely vital. Why is that?
Because the body handles lithium and sodium similarly in the kidneys. If you get dehydrated or drastically cut your salt intake, your body holds on to lithium more tightly to compensate, and the levels can shoot up into that toxic range very quickly.
Wow. So stay hydrated, keep salt intake stable.
Crucial. And it's also important to know that common pain relievers, NSAIDs like ibuprofen or naproxen, can also increase lithium levels by affecting how the kidneys handle it. So generally avoid those unless specifically okayed by the doctor.
Good to know. What if someone can't tolerate lithium or it doesn't work well enough?
Then anticonvulsant medications are often used as mood stabilizers. Drugs like valproate, Depakote, or carbamazepine, Tegretol. They were originally for seizures, but they also help relieve mania symptoms and reduce the severity and frequency of mood swings in bipolar disorder.
Okay, alternative options there.
Yes.
All right, as our journey through this Mind's Pharmacy nears its end, let's quickly shine a light on a few other critical areas. Managing anxiety, ADHD, and maybe supporting cognitive function in conditions like Alzheimer's.
Sounds good. For anxiety, benzodiazepines are commonly used. Diazepam, Valium, alprazolam, Xanax.
The benzos.
Right. They work by depressing the central nervous system, primarily by enhancing the effect of GABA. GABA is an inhibitory neurotransmitter. It essentially calms the brain's activity down.
Effective for anxiety then, but there's a big downside.
A very big one. What's crucial to know is that they are highly addictive. There's a significant risk of developing dependency, tolerance needing more for the same effect, and potentially severe withdrawal symptoms if stopped abruptly.
So short-term use is generally preferred.
Ideally, yes, or very carefully managed long-term use. It's also important to know the antidote for overdose is flumazenol.
Flumazenol, got it. Are there non-addictive options for anxiety?
Yes, as alternatives, medications like Buspirone, Buspar exist. It's less addictive, doesn't cause the same level of CNS depression or sedation.
That sounds better.
It is safer long-term, but the trade-off is it takes longer to work. Typically 2 to 4 weeks to reach its full therapeutic effect. It's not for immediate panic relief like a benzodiazepine might be.
Okay, a different kind of tool. What about ADHD?
For ADHD, psychostimulants are the primary treatment. Methylphenidate, Ritalin, and amphetamine salts like Adderall XR are common examples.
Stimulants for hyperactivity. Seems counterintuitive.
It does, but their action involves increasing the levels of certain neurotransmitters, specifically dopamine and norepinephrine, particularly in the areas of the brain responsible for focus, attention, and impulse control. This actually helps calm and focus the individual.
Ah, okay. Side effects.
Common side effects include appetite suppression, which can sometimes lead to weight loss, especially in kids, and also insomnia or trouble sleeping. So timing the doses and monitoring growth and sleep are important.
Right. And finally, Alzheimer's disease.
For Alzheimer's, we have drugs like Dunham-Piesel, Aricept. These are cholinesterase inhibitors.
Cholinesterase inhibitors?
Yeah.
What do they do?
They work by inhibiting cholinesterase, which is the enzyme that naturally breaks down acetylcholine in the brain. By blocking that enzyme, they increase the levels of acetylcholine, a neurotransmitter important for memory and learning.
So they boost memory signals.
That's the aim, to help with symptoms and potentially slow the progression of the dementia somewhat.
But it's important to be clear here, right?
Extremely important. This is a key distinction. These medications do not cure Alzheimer's disease. There is currently no cure.
Right.
They only help to manage symptoms or slow the decline for a period. It's about offering symptomatic relief and maybe maintaining function for longer, rather than reversing the underlying disease process itself.
Okay. Good distinction to make. Wow, we've really covered a vast and intricate landscape here. Medications designed to manage incredibly complex conditions.
It's quite a spectrum.
Yeah, from the powerful, sometimes maybe blunt dopamine blockade of those first-gen antipsychotics to the more nuanced serotonin-dopamine interactions of the newer ones, and that delicate, really tight balance required for something like lithium. It's crystal clear these aren't simple pills.
Not at all.
Each class, really each drug, seems to have a specific purpose, an intricate mechanism, and its own unique profile of benefits and crucially critical risks.
Absolutely. This deep dive, I think, really highlights the incredible power these medications hold, the power to genuinely alter brain chemistry that offers both profound therapeutic potential.
Life-changing potential.
Life-changing, yes, but also significant potential challenges and risks. It kind of raises an important closing question, doesn't it?
That all.
Given all these intricate mechanisms, all the potential side effects we've discussed today, how does really understanding these details empower you, the listener, to engage more actively, more critically, to talk with healthcare providers about treatment plans?
Yeah, how does it help you ensure the safest, most effective path forward, whether it's for yourself or for someone you care about?
Exactly. It really comes down to being informed, doesn't it? Asking the right questions, understanding the why behind a medication, the what to watch for, truly becoming a proactive partner in your own care or the care of a loved one.
A partner in care, I like that. Being informed isn't about second-guessing doctors, but about participating fully.
Precisely. It's about shared decision-making based on the best possible understanding.